Guys, welcome to another episode of Foresight TV. I am today talking to Anne Tumlinson. She is a genuine expert in the world of so much of senior living and family caregiving. And this is going to be a great conversation. What sort of started this was a presentation that she led at the Nick Spring Conference a few months ago. But we're going to go much further than just what that was talking about, what that was about. And we'll get to it right after this. Hey guys, Steve Moran here. So, Anne, I want to start in a little bit different way before we talk about your background. So you do all this work on policy and mostly with operators and payers and all that stuff. But it also seems like you're playing both sides against the middle because you also have this not-for-profit called Daughterhood that's all about the family caregiver. And until I was prepping for this and thinking about it, it was kind of like, unfortunately, I think they should be like this, but I think they're more like this too often. So talk to me about that.
Sure. Well, that's exactly why I founded the organization, which is that, like so many people in the industry, I have a viewpoint of how things operate, what the payment policies are in healthcare, so skilled nursing facilities, home health, and I kind of stumbled into starting to have conversations with family caregivers, like we all do, which is through our own family, and began to realize that I was missing a really important perspective in the work that I was doing. And so I kind of opened up this channel of communication with family caregivers and myself, and it ended up evolving over time into a community where we provide support, peer support and other programs. But what it essentially enables me to do is to draw on, I call it my anthropological work, which is I get to be in community with these family caregivers and hear things about their experiences that really changes how I see what it is that as senior living operators do, or healthcare providers do, or policymakers do. And just to give you just a quick example, because I think this is one everybody will relate to, during COVID, there was this rush to stand up to, waive regulations to enable hospitals and skilled nursing facilities and other healthcare providers to deliver healthcare at home. One of the number one stress points that I hear from my family members in the family members who are in the Daughterhood community is just how much actual medical care responsibility falls on their shoulders when they are providing care in the home. And I had my own experience with that. And so we went to the AARP Public Policy Institute and we partnered with them to essentially craft a set of policy guidelines for CMS and for hospitals and health systems around hospital at home, to make sure that if we're moving hospital at home, we're not overly reliant on family caregivers to deliver medical care that they're not trained for. And that insight that we needed to do that came directly from talking to and hearing the stories of the family members of Daughterhood.
Yeah, it is so hard. And the other thing that I don't know whether you're addressing this, I'd love to hear your thoughts on it. So as my audience knows, I'm responsible for my 93-year-old stepfather who lives in a small senior living community, a 6-bed residential home. And we're very fortunate. He was very careful with his money. And then he accidentally, or I don't know, maybe on purpose, bought a small number of shares of this little company called NVIDIA, and it just kept growing and growing and growing. And so it's growing into a small fortune. So we don't have any problems. We don't have the money challenges that many people have. But honestly, even with him in a community that's really good, that I'm really, really happy with, I'm an evangelist for the operator. It's a lot of work. I get calls every week. I get texts every week, and some of it's just informational, but I've still got to process it. Sometimes I get called. I got a call 2 weeks ago. I was getting ready to go top golf with some friends, and phone rings, and it's the Saturday night, and I see that it's the senior living care community. I guarantee you that's not good news. And he'd taken a fall. He was fine, but it's a lot of work, and
Yeah.
I don't think that we spend enough time thinking about that as operators, as the industry.
Yeah, I agree. And in fact, when I first started Daughterhood, one of the things that I was hearing the most from the community was, my family is spending all this money. We're spending, I heard this one woman said to me, she goes, my parents are in the top 5% or the top 1%. They're very wealthy. They're in this very fancy community. They have spent a lot of their money on entry fees, et cetera, et cetera, et cetera. And she goes, so why am I in charge of everything? And then she describes this like laborious process of essentially coordinating the aides in the community around, and the different nursing staff and et cetera, around medication management. And if she was just heavily involved in the day-to-day management of the care needs of her family members and her parents. And that was, that was a kind of eye-opening moment for me. And it was early in my journey of working with some of the members of the senior living industry around, what are the levers or strategies that we can deploy in senior living to bring more care management, chronic care management, medication therapy management, all of those pieces that are typically reimbursed through the Medicare program into senior living, so that the operators have the resources and the staff and the skills that they need in order to do more of that role that is now falling lots of times to family members, especially the care coordination. That's the piece that really is missed. So if somebody's in senior living and they fall and they go to the emergency room or they go to a hospital, that's kind of that's like out of sight, out of mind kind of situation for the senior living community. It's like off they go when they come back, but there's not a sense of, now suddenly it's my problem again to manage. And that's how I got to know Lynn Katzman originally, was by kind of evangelizing about this and the opportunities for senior living organizations to take advantage of the value-based care environment, partner with healthcare organizations, partner with value-based care organizations, bring more care coordination, prevention, primary care on site, to reduce the burden on the family members who are already paying, $70,000, $80,000 a year. And we can talk about the lower income distribution, part of the distribution. But at the time, what was interesting to me was, even when you have a lot of money, there's nothing to buy. If you want to solve this problem by spending money, there's nothing to buy that's going to solve this problem for you, which is, this friction between what's happening in senior living and what the family has to deal with. And so that was very instructive for me.
Yeah, it's a very difficult problem. I mean, sort of in my own care journey, the hospice, he's on hospice, been on hospice for a year. We're really glad that he's on hospice. It gives us a lot of extra services, a lot of extra eyes on him. But I get this message from the nurse saying, the community says that he's been experiencing some sundowner symptoms, and so we're going to increase this drug medication. Except that I'm looking at it and I'm thinking, that'll probably calm him down, but it'll also make him less steady on his feet.
Mm-hmm.
And I've got enough knowledge to say, I don't do anything yet. Let me think about this. And I finally came back and said, no, we're not going to do that. But the problem that I see, and then he ended up with a UTI and at the hospital for a few hours. And again, just like you described, right? He's off to the hospital. That's now my responsibility, and I've got to make all of these decisions. And I'm pretty knowledgeable, and I'm pretty
Yeah.
assertive on my own stuff. But what do families who don't have that skill?
Right.
No,
Right.
there's nobody advocating for the families. It's everything ends up being better for the system. That's a huge problem.
Huge problem. Yeah, huge problem. Yeah, that is 100% the issue right there. You nailed it.
Okay, so I could talk about this all half an hour. We already spent about 10 minutes. Let's back up and talk a little bit about who Anne is and what you do in your daily work life, and how you see the industry.
Awesome. I'd love to. So I am, in addition to being the founder of Daughterhood, and serving as the board chair for that nonprofit organization, I am also the CEO and founder of a healthcare research and advisory services firm called ATI Advisory. And our organization now is about 52 experts who work across the Medicare, Medicaid, programs in serving a wide variety of organizations, including state governments, Medicaid managed care organizations, Medicare Advantage organizations, value-based care organizations, and other provider entities. And my DNA, my personal expertise coming in, starting this firm, actually was in post-acute and long-term care. And the work that we do as a firm is broader than that. But I would say the differentiator or the expertise that we bring to every engagement, whether we're helping, a state government create a better, transition from the prison system into the community for Medicaid, which is a project, for example, that we would do, we are always bringing this lens of the chronic, the highest need population, the complex care population, because that really is where I'm coming from, which is how do we design financing systems, delivery systems, operating models, clinical models, financial models that support better and more high value care delivery for individuals who have very complex care needs, who are using, who might be in the senior living organization, but also have multiple chronic conditions, or who are living in low-income seniors housing and have, food insecurity or transportation needs or social isolation needs. So what we're interested in really is how to take the different service delivery streams, plug holes, find the gaps in care, and then integrate those and deliver them with the person in the middle. And I think getting back to our conversation just a minute ago about Daughterhood and senior living is that the reason why family caregiving is so resonant for me is because I always say, it's like there's no one that's really sitting in that position of the beneficiary, the patient, or the resident. Everybody's kind of bringing this point solution right to the right. It's like, oh, we're your home health provider, or we're your skilled nursing facility provider, and it's very, very hard for those provider organizations, hospitals, health systems, physicians to actually be able, either like practically, technically, or financially, to connect the dots to the other things that are happening for that beneficiary. And so all of the work that we do, and like I said, I manage a team of about 52 people, including a data analytics team. Everything that we do has that lens, like what is ultimately going to result in the highest value of care delivery for the individual patient or resident or whoever it is.
Yeah, it's so complex as you're talking about this. I'm thinking I've been doing battle with my stepfather. He was on hospice in my house for a couple months, and then he went to one community, and then we moved him to another community, which is where I expect him to stay until he passes. But I got a call from a DME provider saying, "Oh, we're coming to pick up the hospital bed and oxygen concentrator that's your house." Well, no, it's not. It was picked up 6 months ago. Well, somebody's responsible for it. I'm not responsible. And so I spent 2 hours convincing them that this wasn't my problem. And you've got these tiny, all these little, as you say, point solutions, and nobody's coordinating the whole thing, and it makes it super expensive.
Yeah. Oh, very expensive. And I do think, I mean, this is where I have and remain optimistic about value-based care writ large, especially for older adults and frail older adults, because there's really no other pathway to align financial incentives with better care coordination and better, cross-setting care delivery. And, so I'll give you, I had a very similar example with my dad in home health and DME, and the one physician and one specialist. And, I wrote an article actually for Health Affairs a few years ago about my experience, what my family's experience of home health taught me about healthcare at home. And one of the things that I noted was just that I felt like a switchboard operator. I was the one that was, sitting there kind of like, talking to one nurse here and then calling this person and trying to figure out the schedule and all the things. And, while running a company and having 2 teenage kids, and it, like, people refer to this as the sandwich generation, but it's more like the marshmallow generation, where it's like, we're really squished. So, so that value-based care, the whole point of value-based care, for people who don't, I'm sure every single person in your audience has heard this term 100 bazillion times, but it just refers to moving away from this mindset that we're delivering these units of service for a price for a unit of service. So if you're a senior living operator, you're not really thinking this way, right? You're charging per resident per month. You might have some, add-ons or bespoke things but if you're a therapy provider, though, if you also have a therapy business, you understand this, right? It's a therapy visit is an encounter. It's a unit of service. You get paid an amount that corresponds to that. And the more units of service you deliver, the better you do financially. So value-based care is trying to break that connection between volume and making money, and essentially reattach it around making money is, hey, that person doesn't need therapy today. I'm going to make sure what they really need or they don't need physical therapy, even though that's the appointment scheduled. I'm going to call my colleague and get the speech therapist over here because that's really what's presenting right now. We're going to be flexible, or bring in there's more of a skilled need today. Let's bring in the nurse practitioner, or, or like maybe it's just something like just socialization and talking and light exercise or taking a walk. That's what's really going to make a difference for this person today. And as a provider, I can see that. And because the payment is not dependent on me delivering that therapy that day, I can actually make a different decision that ultimately generates higher value for the healthcare system and for the patient. And I feel like for residents of senior living, there could be almost no better payment system for healthcare for that resident population than value-based care, given how high their needs are.
So at virtually every conference, at least conferences that are sort of geared towards the C-suite, there is at least one, and often many presentations where value-based care gets talked about.
Yes.
But I don't. Are there people who actually have figured it out? Operators who figured it out? You named Lynn Katzman. My guess is she's probably about as far along as anybody. And I think so often what operators tend to hear is value-based care. I mean, it's they sort of acknowledge that it's about making life better for residents, but I think mostly what operators hear is it's a way for me to get extra dollars. Is that, and so talk to me about, I guess the question is how do I, if I'm an operator and maybe I'm doing value-based care, but I don't feel like it's working like it's supposed to, though I don't know why, or I haven't done value-based care because it feels so complex. How do I start thinking about it differently?
Yeah. Well, so first of all, I just want to acknowledge that it's really easy for a consultant to stand up on a stage and tell everybody that they need to be doing value-based care, which is a lot of times what I do. And it always feels a little bit like I want to have a deeper conversation about it, because it sounds like a no-brainer in many respects. There's healthcare dollars on the table.
Yep.
It's you don't have to do this out of the goodness of your heart. You don't have to add expenses. You can add revenue. You can add net income if you do it right on all of the things. It can be hard and challenging because you are disrupting workflows in your building. And you're disrupting, you're potentially disrupting your overall financial model, the model that how. Like, I'm an operator. My role, or my responsibility is to my investor. I need to generate NOI. I know how to do that. This is how I do it. Like, why would I do something different? And particularly in healthcare, where there's kind of added liability, there's added relationships to be managed. There's, yes, you're saying there's more money, but it's not like senior living fee money. It's like, oh, like if I do all of this work,
Yeah.
we get a little bit more money. So it can feel like a really tone deaf presentation that you're listening to if you're an operator, when you're listening to somebody like me. Having said that, and I will get to the how in a minute, I do think that the future of senior living will have to me, and I'm not an operator obviously, but like to me, value-based payment is a means to an end. It's a means to getting a superior product into the market, which ultimately will generate better NOI for your investor. This is old, and I do believe in that. I do think it takes a lot of imagination and initiative in order to get from where we typically are with the product to a product that has a high level of integration with healthcare and is delivering value-based care to the residents in the building. So those steps are not easy. And also the market that you're in can be easier or harder in which to do that, because you're dealing with the healthcare infrastructure, and every market is really different. If you try to do it here in DC, you're going to struggle where I live, because there's not much managed care, there's not much value-based care. Everything's still really fee-for-service, volume-based. You're going to be pushing a boulder up a hill if you're, Inglebrook down on Military Avenue in my backyard. So but the good news for the industry is that increasingly there are organizations that can help bring the different pieces and the parts of the puzzle to align the payment or the contract, the value-based contract with whoever the payer is, the clinical model, which you can either outsource or you can develop in-house, and your building's operating model, the model that you're using, and you have to kind of essentially bring those pieces together, working with oftentimes a partner. And those partners are well known to the industry at this point, and I think there's still evolution to be done with respect to the solutions that are available. So I think you can go that route where you say, like, I really want to work with Curana, or I want to work with Centered Care. There's a number of organizations you can. Bluestone Physician Services is an organization that has a value-based. They have an ACO and they bring their physicians in, and they can begin to set up those care models in your building. But if you want to do more of it, if you want to own more of those pieces, then you can go kind of what I call the Juniper model, which is where you say, all right, I am going to either buy, or actually in Presbyterian Homes and Services in Minneapolis, or Marquee, which is called Age Right in in Oregon,
In Oregon,
which
yeah.
is like, hey, you know what? I don't think of myself anymore like a senior living operator. I think of myself as an organization that delivers care and services to older adults who have high levels of need, regardless of where they live, right? And we can provide them with senior living, but we also have primary care. We also have long-term care pharmacy, or we have all these pieces sitting underneath a value-based care umbrella or a Medicare Advantage plan. And in doing that, we have more flexibility with the dollars, and we can finance care coordination. It's in our best interest now to have the care coordinated. And so Lynn certainly has been pioneering much of this, but there are many, many organizations that have in fact taken this on themselves and developed it themselves without necessarily, outsourcing all of it to, an enablement company like a Curana. And then there's plenty who choose to do that too. I do think, Steve, we're getting a little bit of like frothy. I think we're starting to see it unfold. And I strongly believe, as I said at the beginning of this monologue, that this is going to be the superior product, senior living product in the future.
Well, I think part of the problem that I really struggle with is that even in the world of senior living, and I would include skilled nursing in that, we have a very difficult time talking about what we are. There are people who look at senior living and saying, well, getting old is not decline, it's just getting old and a shift in life, and it should be a lifestyle product. And there are others who are saying, and what this is my camp, is that even when people move into independent living and they're still pretty active, they're still making that decision because they're anticipating decline down the road. So I'm 71. I live in a single story house, a half acre. I've got 3 dogs, 3 cats, 10 chickens. I've got a garden. I've got some fruit trees.
That sounds nice.
I'm not going into senior living anytime soon because I'd have to give up essentially all of that. And there might come a time, but it's probably at least 10 years down the road, unless some health catastrophe happens to me or my wife. And so I think that we struggle with that. And then, there's sort of competition and we don't like each other very much sometimes. But the biggest thing to me is that it feels like the hospitals don't think very much of us and they don't want to talk to us. And if they do, it's very grudgingly. How do we get through that? I mean, I've even talked to some operators who are operating senior living community and they're part of a hospital healthcare system and they have a hard time.
Yeah. Well, hospitals just can't, they cannot, they do not have the bandwidth or the interest to think about senior living or even post-acute care. I mean, the mindset of a hospital CEO, especially right now, or even anyone in the C-suite, like the problems that they are solving are like a really, really huge. And what I mean by that's what I mean is like they are under so much margin pressure. You talk about an operating model that needs to be disrupted and will be disrupted very significantly in the next 10 years. It is how hospitals and health systems operate. They have so much overhead. They are so expensive. They're charging really high prices when they can. They're in an arms race with the health insurers over who can get more leverage in any one market. It's driving up healthcare costs. I mean, it's, we're living in our senior living world over here where we're dealing with older adults who are largely on Medicare. And then you have to understand that you're part of this, your residents are part of this healthcare ecosystem that is facing all of these other pressures. And, not the least of which is, these massive, massive cuts in federal Medicaid spending. So hospitals are kind of like, maybe just to drive this point home a little bit for the audience, just how significant the pressures are. We have this new value-based care model coming out that's come out already called the TEAM model. And it's a post-acute care bundle around a handful of clinical conditions that are mostly surgical. And it's mandatory. So it's being imposed on hospitals without their consent. Not every hospital in select markets. And it is essentially holding them to account for post-acute care spending for a period of time for these conditions. And they will next year, starting in January, they will be at risk for downside risk. Like they will have to pay the government back if they do not hit certain spending benchmarks for all of these things that happen outside of the walls of their hospital. They're not paying any attention to it at all. They're not really paying any attention to it. They can't. That's like, okay, well, that's not going to be a big hit to my P&L. I got a bigger hits over here. I got to figure out how to get all of these homeless people out of my emergency room because all of these people who were covered by the ACA who are now not covered, all of these people covered by Medicaid are not covered. Medicaid's getting cut. Medicare Advantage is there. Boy, I mean, so much friction around Medicare Advantage. So it's this way. This isn't a very hopeful message, but I think that to the extent that a senior living operator really wants to have good engagement with the hospital or health system in the market, they have to appeal to them on the thing that they care about the most, which is getting people discharged quickly and easily. They don't want your residents. They really do not want your residents. Your residents are money losers for them. Yeah. So to the extent you can keep them out of their hospital, and or if they have to go, move them through the day, and or if they're operating a value-based care organization, offer to have a little space in your community for a primary care person to come in and do basic kinds of triage and things like that. Like there are ways to make their lives easier, but other than that, they're not going to be engaged, really.
Yeah. So to me, it seems like that here in Sacramento, where I live, we've got three big systems here: Sutter, Dignity, and the UC Davis system. And I'm looking at that, and I'm thinking, if they were working together, we could the assisted living, the memory care providers could keep people out of the hospital, give them a better experience, and that would save the hospitals a lot of money. It would make the operators a lot of money. But I think that figuring out how to get it to talk to people to even have these conversations seems to be the biggest problem of all. And how do you break through that? How do you even get somebody to talk to you to get to the table?
I don't know, Steve. You just keep trying. You just have to, it's a sales challenge. I mean, it's ultimately because what you're selling is that that it is worth their time to engage with you and to develop solutions with you for your resident population, or to bring you into kind of their orbit in whatever shape or form. And it is a sales challenge. It is really about finding the right person and having the right conversation with that person. So, and some health systems are just they're not well run. I mean, it's just, I was talking to the CEO of a really large system in Virginia that's extremely well run. And I have I have such high regard for him. And he said, Anne, 50% of the hospital health systems in this country are basically, they're not great.
Yeah.
So I was like, he goes, 50% are okay, 50% not great. It's there's a real issue right now with leadership in that sector being, ready to retire.
Yeah, it's such an interesting thing, because I see leaders of hospital systems in the Northern California area who win these big awards, and caring for team members and caring for patients. And I go, I talk to your patients. I talk to your team members just walking around. They hate your organization, and there's this big disconnect. So we are past time. I could do this for another hour with you. This is so much fun. I want to ask you sort of a long-term question. Is 5-10 years, is it going to be better or is it going to be worse?
Oh, it's going to be better, Steve. It's going to be better.
Is it?
Yeah.
Or will it completely fall apart?
Well, it might fall apart before it gets better, but it will be better. I have a lot of confidence. I think we're getting there with our payments. It just takes we're pushing a boulder up a hill right now, and it may be that some things are going to have to get really disrupted before we see any fundamental changes. But I don't, there's no path forward where I think we can feasibly. I just have a lot of optimism. I think there's a lot of people still doing really innovative things. The capital wants to flow to innovation. It's just a matter of maybe getting through the next handful of years, while a lot of that is kind of sort of like I think we planted a lot of seeds. We're getting through winter. It's going to be spring. It's going to get better.
Good. Oh, you made that. I love that. Maybe if I'm still doing this in 5 years, we'll have to check again and see how that goes. And thank you for joining me. But before we sign off, talk to me a little bit about what you do, how you help operators, how people get in touch with you.
Oh, yeah, sure. So it's easy to reach out, Anne, ANNE, at Anne Tumlinson. I'm sorry, that's not right. Oh, you could do that. But Anne at atiadvisory.com, or go to our website. There are plenty of places you can sort of submit an email, reach out to me on LinkedIn, any of those things. I'm always happy to talk. We work with operators, helping them develop their value-based care strategy, pick their partners, make investment decisions about which assets they want to acquire, partner, JVs, all of those different kinds of deals and arrangements we can help with.
Cool. And thank you so much for joining me. Great conversation. I just wish we had more time. Thank you for watching today. We'll be back in a few days with another great show.